Morning, everybody. Welcome to Grand Rounds. Welcome to those that are here in the audience and those online. Before I introduce our speaker, I wanted to just make a land acknowledgement that we acknowledge that we're gathered and are grateful to live and work and play on traditional and ancestral in the unceded territory of the Coast Salish people. And before I introduce our speaker, those people online, if you don't mind muting yourselves. So it's a pleasure to introduce Dr. Leger, Dr. Chantal Leger, a member of the Division of Hematology for a number of years, who's going to be updating us today, as you can see by the title, on CAR T cells and bispecific T cell engaging antibodies. Chantal.
Thank you. Yeah, so I've been at St. Paul's for a while, 20 years now. Time flies. But yeah, so I'd like to talk about CAR T cell therapy today and bispecific antibodies. And now, in my time, I've seen a lot of treatment breakthroughs when it comes to hematologic malignancies. And but I have to say, CAR T cell therapy is definitely one of the major breakthroughs. So I'd like to hear. Oh, can you hear me? Please mute whoever's online. And can you hear me? Okay, we're good. All right. Thank you. So I just like to know in the audience, who's heard of CAR T cell therapy and bispecific antibodies? I know the gang back there has, the hematology gang. Thank you for being here. So yeah, so when you look at cancer immunotherapy, I initially thought this was a modern day invention, but looking back, it actually goes back to the 1800s. And this goes back to, now I wrote this down. So back in the 1800s, in 1860, two German physicists independently observed tumor regression in patients infected with erysipelas. So presumably the immune system was doing something to fight off this tumor. In the 1890s here, and I think you can see my pointer. Yeah, you can. So Dr. William Cawley in 1890s, he's known as the father of cancer immunotherapy. He was a surgeon and cancer researcher in New York. And what he was using with his patients with malignant tumors, he was actually injecting them with live bacteria. And this was known as Cawley's toxins. And it actually achieved complete regression of tumors in many of the 1,000 patients that he treated. So presumably, again, the immune system was fighting off this tumor. So Cawley's toxin was actually used up until the 1940s, but then you could imagine injecting people with live bacteria kind of fell out of favor. And by 1960s, it was discontinued when obviously radiation and chemotherapy came to be the standard of care. So now you fast forward to the 2000s, 2008, when the first CAR T cell was developed. And then you have the immune checkpoint inhibitors in 2010, and then the approval in 2017 of the first two CAR T cell therapies for B-cell CD19 positive malignancies. So let's start with a case, a patient of mine who was initially diagnosed, 21-year-old female. She was a student at the time. She presented to St. Paul's with severe right upper quadrant pain and fever. And she had a large mediastinal mass, liver involvement, and splenic involvement. And she was diagnosed with stage 4B diffuse large B-cell lymphoma. So you'll recall the standard of care is usually R-CHOP. She obviously received this, failed to respond. She progressed, received salvage treatment, radiation, then went on to further treatment with other regimens, one known as polatuzumab, bendamustine, rituximab. She was refractory to all treatments, 21 years old. She had progressive lymphoma. So at that time, CAR T cell therapy was not offered in Vancouver outside of a clinical trial. And so she went to Toronto. And she received CAR T cell therapy with Yescarta, Axi-cell, and her infusion date was March 30th, 2023. So, all right. So this is supposed to work, and I knew this would happen. Okay, I see the little arrow. Okay, so what is CAR T cell therapy? This is a great video by the Leukemia Lymphoma Society, and I do encourage my patients who want to hear more about CAR T cell therapy to go and look at this video. So I thought I would show it to you, and then we can discuss things in more detail.
At LLS, we always say that beating cancer is in our blood. It's a phrase that captures the heart and soul of what we do. But what if your own blood could actually be turned into a meaner, leaner, cancer-beating machine? Well, that's what doctors and researchers are doing right now with something called chimeric antigen receptor T cell, or CAR T cell therapy. To understand it, we need to start with T cells, a type of white blood cell that patrols our bodies for signs of disease. See, all cells have protein fragments called antigens on their surface. Some antigens are tumor-specific, meaning they're specific to certain cancers. And it is these tumor-specific antigens that ultimately alert your body's immune system, specifically your T cells. See, T cells have receptors on their surface that are uniquely designed to latch onto antigens of cancer cells. They then kill the harmful cells by injecting them with toxins. It's a pretty amazing system when it works. The trouble is, cancer is smart. Cancer cells can disguise themselves so our T cells don't recognize them as foreign. And when that happens, the cancer grows, leaving one of your body's most powerful defenses, well, kind of powerless. So researchers asked themselves, what if we could reprogram a person's own T cells to break through cancer's defenses? And that's what CAR T cell therapy is all about. In a nutshell, the doctor takes out some of your own T cells and sends them to a lab. The laboratory technicians turns them into super cells, CAR T cells. They do this by modifying the new CAR T cell receptors to recognize your specific cancer and make those receptors, well, more receptive to its antigens. The new cells are reproduced a few million times and then frozen so doctors can begin treatment when the time is best for you. Before you're able to get your new CAR T cells, you'll be given something called lymphodepleting chemotherapy, which will make room for your new super cells. Then, when it's time, your doctor will introduce the new and improved T cells back into your body. The good news is that they start attacking the harmful cells right away. The bad news is that the therapy has a high likelihood of causing side effects and making you sick. Many patients experience symptoms typical to a bad case of the flu. Patients also report nausea, dizziness, and loss of balance, among other symptoms. And make no mistake, in some rare cases, patients can experience more serious side effects, like confusion, seizures, and even stroke-like symptoms. Your doctors will want to monitor your condition, so they'll likely require you to stay near a hospital or perhaps even check into one. But for many patients, these side effects are temporary and can be managed with medications or other procedures. What's more, researchers are making great strides in controlling and reducing those side effects. So what happens after the sickness passes? Well, this is the really good part. These stronger and faster CAR T cells just keep reproducing in your body for a long time after the infusion, continuing to fight the cancer if it returns. And in many cases, they continue to work long after a patient enters remission. Right now, this therapy is typically only given to patients with specific types of blood cancer who have not responded to common cancer treatments. And only your doctor can tell you if this therapy is a real option for you. But while the results are early, they're incredibly promising. And encouraging studies for other types of blood cancers are moving forward at great speed. Yes, beating cancer is in our blood, but the key to beating your cancer might just be in yours.
Okay. Okay, so just to summarize, so CAR T cell therapy is a type of treatment in which a patient's T cells, your autologous, your own T cells, are altered in the laboratory so they will bind and destroy malignant cells. So in the lab, there's a gene for a special receptor called a chimeric antigen receptor, which is inserted into the T cells. Now, these changed T cells are called CAR T cells, and then you get millions of them grown in the lab, and then they're given back to the patient. And then they're able to bind the antigen on the malignant cell and destroy them. Okay, so that's the summary. So here's a description of what it is for a patient who's going through autologous CAR T cell therapy. So initially they would undergo leukapheresis, where the white blood cells are taken out, including the T cells. The T cells are then sent to a manufacturing lab where they are altered and engineered to find and kill cancer cells. Okay, so this is done through an inactive virus, which inserts a gene into the T cells, which turns them into CARs. Okay, and this process generally takes several weeks. It depends on the type of CAR T cell therapy you're receiving, could be 2 to 6 weeks. So during this time, sometimes patient with a high tumor burden of disease will need what we call bridging therapy, so they're able to get to receiving their CAR T cell therapy. So once they're ready, so the patient would receive what we call lymphodepletion therapy to make room for these T cells to be accommodated and expand and proliferate. And once they're reinfused, the CAR T cell is reinfused into the patient's system, then the receptors are attracted to the targets on the surface of the cancer cells, okay? And then what happens, the CAR T cells basically go and destroy the cancer cell. Now, what happens when this happens is a whole succession of issues that can come up, and I'll be talking about the potential complications and toxicities associated with CAR T cell therapy. So how does the CAR T cell recognize and kill the malignant cell? So you'll recall that a normal T cell, in order to recognize an infected cell or a cancer cell, it requires MHC expression. But like they said in the video, cancer cells can be really sneaky and oftentimes downregulate or alter their MHC expression to avoid detection. Now, CAR T cells circumvent this problem because they don't depend on MHC expression, okay? And so basically what happens, this altered CAR has a signaling domain, and when it recognizes the target domain on the tumor cell, there's a downstream effect that occurs in the CAR T cells themselves that leads to proliferation, activation, expansion, and then more and more CAR T cells are available to find these malignant cells, okay? So what happens when the CAR T cell gets activated by the tumor cell, it leads to cytokine release, which is needed for expansion, activation of these killer cells, and this can lead to some issues. So what is the target domain on the tumor cell that's being recognized? So we need to go back to medical school and talk about expression of antigens and clusters of differentiations on blood cells. So you'll recall that T and B cells express unique combinations of CD markers on their surface. So these markers help identify the type, the stage of development, and the functional state of a cell. Now, the interesting thing is that neoplastic cells also express these markers, and this is what the CAR T cell is using to identify its target, okay? So most of the CAR T cell therapies available right now target what we call CD19 and BCMA, so B cell maturation antigen, which is found on the plasma cell, and CD19 is found on B cell malignancies. So this is a big slide, but basically what I want to tell you is there are 6 currently approved CAR T cell therapies, and they all have very interesting names that are truly tongue twisters, so you have to say them over and over again to get them right. But generally what we just put them into a shorter word like axi-cell, brexi-cell, lyso-cell, tiso-cell, etc. So there are 4. The CARs are directed against CD19, which again is expressed on the surface of the vast majority of B cells, including B cell malignancies, and for multiple myeloma. So the CARs there would be directed against BCMA, which is expressed on the surface of malignant plasma cells, okay? So many additional CAR targets are under investigation at the moment to treat solid tumors, other hematologic malignancies, and non-malignant conditions. Now I can talk about that a bit later. So you can't look at a journal or journals these days and not find something about CAR T cell therapy. It's everywhere. So in the New England, the Lancet, etc., it's everywhere and it's making the news. And so the most advanced clinical trials have evaluated CD19 CAR T cell therapies. And this is Axi-cell is actually what our patient received in Toronto. So in this 2017 early trial, in a phase 2 trial, just over 100 patients with diffuse large B-cell lymphoma, which is a common aggressive B-cell malignancy, and primary mediastinal B-cell lymphoma or transformed lymphoma received this type of CAR T-cell therapy. So in these patients had been heavily pretreated before. So they had failed the R-CHOP, the salvage therapy, etc. So at this point, their life expectancy would be quite short. And so you would not expect them to respond to very much anything. But in this case, they had a response rate of over 80% and a complete remission of over 50%. And fast forward, there are some patients that are being cured even after lots of prior treatment. So in this particular paper, the overall rate of survival at 18 months was 52%, which was actually quite impressive. And more trials now are looking at bringing CAR T-cell therapy early in the course of treatment, as opposed to waiting when the patient is really out of options. So this is just an example of all the New England, some of the New England, the Lancet papers, etc., of papers that have been published. And so before we move on to what happens when you get CAR T-cell therapy and the potential complications and toxicities, the reason I was bringing bispecific T-cell engaging antibodies into this conversation was because they have similar side effects. They may not happen as frequently as when patients get CAR T-cells, but they do occur. And what I'm talking about here is cytokine release syndrome and ICANS, and I'll go through that a bit more specifically. So bispecific antibodies are off-the-shelf therapy. They do not need to be produced from the patient's own T cells. They're artificially engineered antibodies that can be manufactured in large quantities ahead of time. And so bispecific, they generally bind two distinct domains, or like two antigens or two epitopes. And you'll recall that typical monoclonal antibodies target one epitope, like rituximab, right? Anti-CD20 monoclonal antibody. In this case, you target two antibodies. And so currently administered at St. Paul's right now, we're administering teclistamab, epcoritamab, and glofitamab for B-cell malignancies and multiple myeloma. So we certainly have some experience with this at St. Paul's Hospital and their potential complications. So just a cartoon of the bispecific antibodies. So you have your bispecific antibody here, whether it's teclistamab or another bispecific. So it engages the T cell and also the cancer cell. So it's basically bringing the cancer cell up close and personal to the killing machine. Okay, so it brings it closer so it can lead to cell killing. So this one here, teclistamab, which we do have experience here with at St. Paul's in our patients who are highly refractory to treatment. So multiple myeloma, you'll recall, you can get autologous transplant, and there are many new great therapies for multiple myeloma, but many patients end up being refractory to all these treatments. So in this particular New England study, they chose patients for treatment with teclistamab, the bispecific and monoclonal antibody that's targeting CD3 on the T cell and BCMA on the multiple myeloma cell. So these patients were what we call triple class refractory, meaning they had received lenalidomide, so an immunomodulatory agent, were refractory to that. They could have received a proteasome inhibitor like bortezomib, refractory to that, and then anti-CD38 monoclonal antibodies, and refractory to that. So at this point, usually it's grim in terms of life expectancy, because there aren't too many options after that, except for bispecific agents and CAR T-cell therapy. So in this particular paper, you can see that these patients would not have been expected to respond very much, but they actually had quite a good response rate, and over 60%. And some of these patients actually went into a complete remission, which is pretty remarkable. So let's go back to our patient. So you'll recall she had primary refractory aggressive lymphoma. And then she was referred to Toronto and received Yescarta, which is the Axi-cell that I showed you in the New England article. And she received this about 2 years ago in 2023. So then the patient returned to Vancouver, and then patients are generally then followed up with their primary hematologist or oncologist. And so on the report, they mentioned that she had had grade 2 cytokine release syndrome, or CRS, and that she had been treated with tocilizumab. And she also had ICANS grade 0. So what does that mean? So there are several risks and possible toxicities associated with CAR T-cell therapy, and today I'll discuss mostly CRS and ICANS, okay? So ICANS means immune effector, cell-associated neurotoxicity. Okay. There is also an HLH-like syndrome that can occur with CAR T-cell therapy, as well as hematotoxicity, which is expected. But these patients can have prolonged cytopenia, sometimes for well over a year. And they also suffer with B-cell aplasia and hypogammaglobulinemia, so an increased risk of infection and opportunistic infections. So this is a timeline of what to expect when. Okay, so CRS, or cytokine release syndrome, generally occurs quite early in the course of treatment, usually within the first week or so. And it generally resolves within about 2 to 3 weeks, depending on the type of management. You can then get the second so an HLH-like syndrome, which may coincide with the CRS and make it really difficult to know, is it CRS, is it HLH? But sometimes the CRS looks like it's getting better, and then something's ramping up again, and that can be HLH. So you really need to think about that. Now, there are many different cytokines associated, so cytokine release syndrome, many cytokines associated with CRS as well as HLH, and that dictates how you're going to treat these patients. So other ones is ICANS, the neurotoxicity, which generally occurs very early on as well. And then this is a particular complication that occurs after a certain type of CAR T-cell therapy used for multiple myeloma. And it's a movement disorder that looks like Parkinsonism or Parkinson. But it looks a bit different, and obviously it can be life-altering and devastating. So that's one potential complication of a particular type of multiple myeloma CAR T-cell therapy. And the next one here are cytopenias. So neutropenia, anemia, thrombocytopenia, to the point where they could require G-CSF or a thrombopoietin agent or regular transfusions. And this can go on for a prolonged period of time, so requires regular monitoring. And then you have the B-cell aplasia, hypogammaglobulinemia, and an increased risk of opportunistic infections. And these patients often require regular IVIG moving forward. And then what I'd like to touch on is the secondary malignancies. Now, so these patients are generally heavily pretreated. So just having received numerous cycles of chemotherapy does put you at risk for myelodysplasia, acute myeloid leukemia. But in addition to that, you do have to watch these patients for secondary malignancies. And in November 2023, the FDA put out a press release, an urgent press release, alerting physicians to the possibility of an increased risk of aggressive T-cell malignancies. Now, it's still rare, but it's obviously a very devastating complications. Like, it's not, the hypothesis, well, is it related to the CAR T-cell therapy, or is it related that patients who end up with CAR T-cell therapy probably have a genetic predisposition to malignancies? So perhaps it's that. We also know that patients with B-cell malignancies have an increased risk of T-cell malignancies. Could it be related to that? Or is it something about the CAR T-cell therapy in and of itself? So this requires lifelong monitoring. So what is cytokine release syndrome? Okay, so in a nutshell, it's a systemic inflammatory response due to high circulating levels of inflammatory cytokines resulting from CAR T-cell expansion and activation in response to tumor antigen binding. Okay, so I usually think of it sort of, you think cytokine storm, evil humors. I think, hyperinflammatory, the hyperinflammatory horse has left the barn kind of thing, and it's a mess, right? And so patients can present with a flu-like illness, or it can be much more severe than that, leading to hemodynamic compromise, ICU, requiring intubation, can also lead to renal failure, etc. And so these patients really require a multidisciplinary healthcare team and can definitely end up in the intensive care unit. So Okay, so in terms of guidelines, so how do we grade CRS and ICANS? So the ASTCT, American Society of Transplantation and Cellular Therapy, have come up with guidelines. And these are very useful to determine, one, the severity of the CRS and ICANS, but also the grading is helpful in determining treatment and guiding treatment. So CRS generally starts with a fever. Okay, so that's your first thing that alerts you to CRS. Next thing you do to grade the CRS is that you look at the blood pressure. Does the patient have hypotension? Does it respond to fluids? Does it require numerous pressors? Do they need to be in the intensive care unit? Do they need oxygen, a lot of oxygen, or do they need to be intubated? So this is an abstract that was shown at ASH, the American Society of Hematology, in 2023, and I found it interesting because you can see here that it goes through each 6 of the approved CAR T-cell therapies, and that you can see on the first line here that most CAR T-cell therapy is administered in an academic center. Okay, so not surprising. And so here you can see that higher levels of CRS is actually much rarer, and grade 1 and 2 is actually quite common, okay? And that the median time of onset is quite early, so you really need to be aware of what you're looking for. And the onset can be 3 to 4 days, but can be earlier depending on the type of CAR T-cell therapy you're receiving. And the median duration, it's pretty broad, but generally tends to resolve within 2, 3 to 4 weeks, depending on the treatment that you're getting and the grade, of course. And like I said, patients can be quite sick, again, with cardiomyopathies, renal failure, liver failure, and so, but generally those tend to occur with the higher grade CRS. So then I started looking into, are there scores to predict who's going to get a CAR T-cell related therapy? And I came across this E6 score. I don't know how much it's used in practice, but it's quite interesting because we do know that endothelial activation is what's triggering the CAR T-cell related toxicity. And so the E6 score was first devised for patients undergoing an allogeneic transplant. And so when combining the E6 score, which looks at creatinine, LDH, which is a marker of tumor burden, and we know that patients with higher tumor burden are at increased risk of CAR T-cell related toxicities. When you combine this with ferritin, it is predictive of a higher of the presence or the onset of CRS. Okay, when the patient is receiving axi-cell. So this was done in this particular CAR T-cell therapy. And when combined with ferritin and CRP is predictive for ICANS. So, you know, it makes you wonder, could you use scores to try to perhaps administer preemptive therapy to patients who would be more at risk of these complications? So turning our attention to ICANS. So the first was CRS, now ICANS. A disorder characterized by a pathologic process involving the central nervous system following any immune therapy that results in the activation or engagement of endogenous or infused T cells and or other immune effector cells. So symptoms or signs, now a whole range of symptoms or signs. It can present with a headache. It can include things like aphasia, altered level of consciousness, impaired cognitive skills, confusion, motor weakness, and in its more severe form, seizures and cerebral edema. Okay. So why does ICANS occur? So different hypotheses. We do know that ICANS, so in severe, with severe toxicity of CAR T-cell therapy, we mentioned that there's endothelial activation and there's breakdown of the blood-brain barrier, okay? So we can see cytokines in the CSF, but just having CAR T-cells in the CSF doesn't necessarily will lead to ICANS, but you can see certain levels of cytokines in the CSF, okay? And again, those are being looked at to see if we could administer preemptive therapy to avoid the complications of severe ICANS, okay? So CRP and ferritin are often biomarkers for cytokine release syndrome as well as ICANS, okay? But they don't, the CRP, it's, you say, well, you think, well, maybe we can do CRP and ferritin and see which is going up, and then we can preemptively get involved so it doesn't go into a more severe form of CRS or ICANS. But the CRP doesn't have great positive predictive value because it tends to go up while the complication is occurring. So researchers are looking more so at looking at specific cytokines to see if those are going up. But obviously getting real-time cytokine measurements, it's a bit difficult, right? So that's something to think about for the future. So in terms of ICANS grading, so again, it's the same scoring guidelines that I mentioned before. So it starts with an ICE score, and the ICE score can be done at the bedside, easily with the patient, anytime. And so it's actually incorporated in our power plans, in our Cerner power plans. And so it looks at different domains. So orientation, naming, following commands, writing, and attention. Okay. So then you grade the patient. And then what you do, you incorporate your ICANS with other domains of neurologic activity or compromise. So with the ICE score, looking at the patient's level of consciousness, if there are any seizures or any motor findings or evidence of elevated ICP or cerebral edema, which would obviously lead to a higher grade of ICANS, this determines treatment, okay? And obviously, if you have a higher grade, you need to be in the intensive care unit. So how do we treat CRS and ICANS? So there are many different guidelines for both the treatment of ICANS and cytokine release syndrome, but they generally work on the same themes. So for CRS, it's tocilizumab, which is an anti-IL-6 antibody. And for ICANS, it's mostly steroids. And then there are other ones down the line if things are not improving. The issue with tocilizumab, it doesn't cross the blood-brain barrier and therefore is not a viable treatment option for ICANS. So this I found, so like I said, different articles in different journals, and this one here is an excellent primer that I found in the Journal of Intensive Care Medicine, and really goes through things in details in terms of how to approach the toxicities in the intensive care unit. So this is a really good read if you want to follow up on treatment. So the general guidelines for treatment, again, it depends on the grade of the CRS. So grade 1, mostly a fever. So you start with frequent vitals and then supportive care, obviously. You administer IV fluids, you do your septic workup, you look for a differential diagnosis. These patients are at risk for, they're neutropenic, they're, they're immunocompromised on many different levels, so they're increased risk of infection. So you do your septic workup. They are at risk of tumor progression, so you look at that as well. And then you move on. Grade 2, basically you follow grade 1 and then you step it up. And that's where you'd start thinking of administering tocilizumab. Now, there is a push to starting tocilizumab earlier than later because that may prevent the progression to a more severe form of CRS. So by the time you get to grade 2, 3, 4, you should be calling your intensive care unit and transferring the patient. And so tocilizumab as well as steroids are effective. Now, initially, there was concern, could you be decreasing the viability of your CAR T cells by administering tocilizumab? Doesn't appear to be so. Could you be increasing the risk of ICANS by giving too much tocilizumab? Possibly. I mean, many different things are going, and so ongoing research, obviously. So for the ICANS management, also complex, but you think of other etiologies, right? If someone's having a seizure, you look at tumor progression, all sorts of different causes, septic workup, and there the mainstay of treatment is early administration of steroids, and that may decrease the progression to a more severe form of ICANS. So you do your glucose scans, seizure precautions, you're calling your neurology colleagues, and once in the higher level of care, if things are still not right, you consider anakinra, which is an anti-IL-1, okay? So we talk about all these cytokines floating around. So, and the treatment. So the treatments target certain types of cytokines. So we can see here you have your CAR T cell on the left, and then on the macrophage on the right, and they're all secreting cytokines, and so, or inflammatory markers. And so we can see the tocilizumab here on the anti-IL-6 is what is targeted with CRS. So these are generally, IL-6 is generally a marker of macrophage activation. We can also see like IL-10, IL-1, which is targeted by anakinra. And then research moving forward is also looking at other interesting antibodies to certain cytokines, which may be playing a role in contributing to the toxicity. So you have like interferon gamma, so emapalumab, which can be a player in HLH. That could be considered as a targeted treatment. And we're looking at things like dasatinib, which we usually think for the treatment of CML, and ruxolitinib for the treatment of myelofibrosis. These are coming into play as well because these T cells are dependent on kinases for T cell activation and proliferation. So perhaps targeting and down-regulating these pathways may actually help with resolution or alleviating some of these complications. So this is a lot for patients to remember, right? I mean, you know, you go home, most of these treatments are CAR T cell therapy currently being given as an inpatient treatment. But moving forward, just like autologous transplants used to be in the inpatient setting, they're all out in the outpatient setting now. So eventually, these patients will be outpatients, whether it's after they receive their inpatient CAR T cell therapy or down the road, perhaps they'll be outpatients from the get-go. And teclistamab, you'll recall, is a bispecific agent, and bispecific agents also have a risk of CRS and ICANS, although to a lesser degree than CAR T cell therapy. So these patients are usually sent home with, for CAR T cell therapy, obviously an information package for themselves and for a caregiver. They're generally required to have a permanent caregiver at home with them, and to be, in general, in the vicinity of an academic center that knows how to treat them for at least a month after their CAR T cell therapy. And so these patients then carry a card with them, so they could very well show up to the emergency department reporting some of these symptoms, and they'll have a card which tells them, you know, when they receive their first dose, their step-up dose, etc. So you can really kind of time what they're coming in for with the administration of the treatment. So back to our patient. All right, so she's in Toronto, got her treatment March 30th, 2023. So good news stories. So she did have some complications, grade 2 CRS, received tocilizumab, ICANS grade 0, fortunately. Other complications, because they're at risk of sepsis, culture-negative febrile neutropenia and parainfluenza infection. And her day 30 PET scan to monitor her disease showed partial metabolic response. And since this time, she's had serial PET scans. These patients need to be followed very closely over time. And the last one was January 2025 and showed no worrisome FDG avid lesions. So this is a young patient who otherwise it would have been a very sad story. But with CAR T cell therapy, she's currently in remission and she's traveling in Mexico at the moment. So that's a good news story. So she could be cured. She has to be followed closely, obviously. So CAR T cell therapy in the first year of follow-up, they require lots of follow-up, TLC, and guidance. So you follow them with regular blood work. You obviously monitor for disease recurrence. And these patients often need IVIG because they're hypogammaglobulinemic and they have B-cell aplasia. They have a higher risk of infection, so they need to be aware to contact their provider if they have any fevers or any signs of an infection. And then at 6 months, they undergo reimmunization. And then down the road, they need to be monitored for secondary malignancies. Now, I can't stress the increased rate of infection. These patients are immunosuppressed on so many different levels, right? They can be neutropenic, this can be prolonged. They have CD4 T cell lymphopenia, B cell aplasia. You can get plasma cell depletion by BCMA-directed CAR T cell therapies. And remember, they've received a lot of immunosuppressive therapies like lymphodepleting therapies like fludarabine and cyclophosphamide. And they often have underlying immune defects that predispose them to malignancies. So these are the infections, everything you can imagine they can get. So they need to be monitored and screened very regularly. So what's the current status of CAR T cell therapy in British Columbia? So over the last year, it is now available for CD19 B cell malignancies, so our patients don't need to travel out of province. It is not currently approved for, there is no current provincial funding for myeloma, but this will come. And so in 2024, 30 patients received CAR T cell therapy, 27 as standard of care, and 3 in research clinical trials. Now, some patients don't make it to CAR T cell therapy. Either their disease is progressing too rapidly, or they don't have enough T cells to manufacture a CAR T cell with. So what's the cost of all this? About $500,000 and this is without necessary, depending on, how many complications and whatnot. So the oldest patient I was told that was treated with CAR T cell therapy was 82. And this is a treatment where the older adult, assuming that you don't have significant comorbidities, are eligible for CAR T cell therapy. So it does open up possibilities where, let's say an allogeneic transplant may not be available or recommended. CAR T cell therapy could be approved. So there are non-hematologic trials coming down the road, possibly one for lupus, so a non-malignant condition, opening later this year. So that's really exciting. So what's the future of CAR T cell therapy? I won't spend too much time on this because this could be around just on its own. There's a lot going on. And so looking at solid tumors, and other hematologic diseases other than B cell and plasma cell malignancies. And this brings up the issue of on-target, off-tumor effect. And that's why it's hard to develop CAR T cell therapy for malignant tumors, because malignant tumors don't always necessarily express one antigen that's not expressed on other tissues, right? So it's expressed on normal tissues. So then there's potential for significant toxicity. What do you do? Another area of research is what do you do with relapse post-CAR T cell therapy, right? So you think about bispecific therapies, you think about another CAR T cell therapy that's targeting another antigen. And this occurs because either the tumor cell loses expression of the target antigen, giving rise to an escape variant. CAR T cell persistence may be limited, or the CARs are immunogenic such that the patient's own immune system destroys them. And then there's also a lot of research going on into how to limit the toxicity associated with CAR T cell therapy. So one that I found particularly interesting is what we call a suicide system, where if someone is having significant, severe, life-threatening complications, CRS or ICANS or HLH driven by the CAR T cell, is there a way to shut off that CAR T cell activity? And so that's being looked at as well, sort of a off switch type of approach. So I think that's about it. So so if you have any questions, and that's it.
Questions for Dr. Leger? Come on, you guys.
I know, it's a lot of information.
So how do you choose who's not a candidate for this therapy?
Right. Well, I usually refer them to the Leukemia BMT program and let them make the decision. I think it's always worth a conversation. Obviously, someone who has significant comorbidities, cardiac disease, but having said that, even patients with less good performance statuses can still be candidates. So I don't rule out anyone. I usually let them have a conversation with the CAR T cell group, and because they're performed at VGH. For bispecifics, again, performance status, burden of disease.
Okay. Yeah. I mean, so there are no specific And in using the monoclonal antibodies prior to using these, you look at TB status, you look at a variety of things. Is that lymphoma group or that T cell or the CAR T cell group? Do they do all of those screenings beforehand, or is that?
Yes, you would. You would usually go through a very thorough, workup to rule out any active infections, anything that could increase your risk of not being able to withstand toxicities or active infections where you're getting more lymphodepleting treatments, et cetera, that could reactivate. So so the patient needs to be chosen carefully. But having said that, it opens the door for patients that may not be eligible for other treatments.
So I've taken up the questions. Anybody in the audience? Yes, please. I'm sorry, I can't see.
Hi. It's going to be a tough question.
For our internal medicine residents, now we're going to be having some patients that have had CAR T, let's say.
Yeah.
What is the range of presentations that they might like present to hospital with, and what are some of the infection things that you should be looking for, kind of on cross coverage or something like that?
That's right. When as these patients sit at home and then they're concerned, they might end up in on our doorstep, right? And so I think, just being aware and calling up your colleagues in hematology when these patients show up and they say they've received CAR T cell therapy or a bispecific agent, I think you need to open up the conversation with your colleagues and your hematology colleagues. I would really want to know if my patient ends up in the emergency department, and so would Dr. Leach, and so would you. And so, and then it's really about, your ABCs, working up your fever, and speaking with your colleagues if they need to go to the intensive care unit. And it's, like I said, it's multidisciplinary. So it can involve your neurologist, your infectious disease specialist, your intensivist. So it's really a group effort. So it's about having that conversation. Oh, just mute your mics.
Can you mute?
Yeah, please.
Can you mute? Thank you.
Yeah, did you have any other thoughts, Gina?
C'est la fin de l'ordre mis en place par les États-Unis et leurs alliés il y a 80 ans.
Okay, please mute your microphone. Thank you.
Cette idée est à la source même de l'ONU. Aujourd'hui, les Américains votent en faveur de l'agresseur.
Yeah.
Avec celle de Poutine. Un retour aux sphères d'influence.
I could answer, but I don't know what they're talking about.
À moi, le Groenland, le Panama et le Canada.
How is it coming through? It's somebody at home?
Yeah, exactly.
Oh, they're listening to the news or something. At the same time.
Le réalisme diplomatique.
Mar-a-Lago, I think I know what they're talking about.
Muting the mic, please.
It's the French defense minister.
Oh, okay. There you go. All right. Okay.
Oh, please. Why don't we just disconnect? Disconnect from that.
Okay.
From Zoom.
Okay.
L'écroulement démographique.